Okay, tamam. Okay, we'll move on. Regarding the needles used, it's either the vacuum-assisted biopsy or in locations where we don't have the VAB, we can use a gun with a 12G needle. And this is available in Egypt. You can get it from Gulf Med or BD. They have the 12G needle with the gun. The indications of the biopsy are something that is not seen by ultrasound. Anything seen by ultrasound, do it ultrasound guided. If it's not seen by ultrasound, like microcalcifications, faint asymmetry, or distortion, you can do it by 2D biopsy. Okay, the approach. The approach can be either be vertical stereotactic biopsy, though the patient is sitting in the CC position and the entry of the needle is vertical, or horizontal. The patient is also sitting in the CC position and the needle comes from the horizontal view. And this is my most favorite position to do a VAB stereotactic biopsy. It's much easier and it's faster. So the needle endles parallel to the breast support. Now, there's also the option of having the prone table, which is not available in many locations because it's very expensive, but also it's very convenient. And there's another option of having a lateral approach with the patient lying down like this, and the compression plate is put in this direction as if it's a CC, but actually it's a lateral view. Now, the technique of 2D biopsy, let's go through this video. So the technician is first putting the the biopsy device onto the machine. And she puts, in some vendors, they have a touch pad. In other vendors, you can use this pad on the screen itself. And the value of this touch pad is if you want to manually change the location of the needle, you can do it. She's adjusting now the compression paddle and making sure that the system has all clicked in position. Okay, now she's going to bring the patient in position, and in this case, the patient is lying down with her breast in the lateral position, okay, but the machine is upright as if it's a CC, but she's lying down, so it's a lateral position, and she's compressing using the foot paddle and putting trying to put the lesion in place. She takes the scout view, and she can see that the calcifications are in the position we need. And then she takes the two 15-degree views, which give us a localization of where exactly the needle should be inserted from the depth, from the lateral, and from the anteroposterior. Okay, she then puts the marker on the calcifications that we want to excise. And then after sterilization, the target goes into position. The target goes to the position that the machine has calculated. Okay, then after that, we're supposed to do the local anesthetic, and there's a laser red spot over there where the anesthetic should be done, and this is in some machines. And then we put the needle guide, which should be disposable. The needle guide is a plastic guide for the needle, and then we put the needle in position. So in this point, we have the option of using a scalpel or not. And if you noticed, she made the needle a bit higher from the depth, so she can take a pre-fire image, okay? Now the needle, she did the scalpel, she opened the scalpel and she put the needle in, and now she's taking a pre-fire stereo pair image to make sure that the location is right. And sometimes after anesthesia, you'll find that the correct location has changed, so you can manually adjust the location on the machine with a simple click of the mouth, so the needle can be adjusted more anterior, more posterior, more deep, whatever we need. Okay, so now we put the needle into the post-fire location, and when you do the post-fire location, the calcifications will be hidden behind the notch of the vacuum, so you won't be able to see it. And after the tissue is removed, the marker is placed. Now, some markers are placed separately, but some markers are placed through the vacuum needle itself. And we should take post-clip insertion position. Okay, never forget the sample image. Okay, the sample should be placed in this plastic box, and we take an image of it to make sure that the calcifications were excised, and this should be done with the patient in the position. The patient shouldn't leave the table before we take the sample, so that we can make sure that everything has been taken and we don't need to reinsert the needle again. Okay, for this case example, this was a linear cluster of calcifications. This is one of the cases we did at the national screening program here in Egypt. This is a linear cluster, and these are the pre-fire and the post-fire images, and this is the clip, the post-biopsy clip in position. And this was the sample showing subtle calcifications. I think you can see them here. Okay, and let's move on to 3D tomosynthesis. So what's the difference? The difference is that we don't take any 2-degree angles. It's just the SCOUT has the tomo in it, has the 3D image in it, just one volume, okay? And we can put our marker straight away on this volume. We don't need to take 2-angle views and a SCOUT view, it's just one image. And these are the pre-fire and the DBT and the post-fire, and here the clip within the position. Okay, moving on to contrast biopsy. So when should we do contrast biopsy? When it's only seen by contrast, okay? And we need to do that after we do the contrast imaging by 2 days, okay? So you've done your contrast biopsy, you've done your contrast mammography, you see the abnormality, you wait 2 days before you do the biopsy again. And so what happens? First of all, the patients usually prefer this than MRI-guided biopsy, and it can be done within 15 minutes, although the MRI biopsy takes about 60 to 90 minutes. So what happens? We do a contrast mammography again, a full procedure of contrast mammography in the same way, and then we have to be doing pre-planning before it. What does that mean? So before we even do the contrast mammography that's right before the biopsy, we plan. We look at the first contrast mammography. And then we, for example, this case, we measure from the nipple till the area of the mass. Then we measure from the center to the mass and from the other direction. And then we know these measurements. We take a ruler, we go to the patient in position of the CC position, and we mark with a permanent marker on her skin where it's expected. Why do we do this planning? Because when we do the contrast mammography before the biopsy, we only have a few minutes, okay, before the contrast becomes delayed. So we should plan in advance, and then we can target easier. So for example, this case, where we have a lesion here, okay, planning was done properly and the target was done, and these are the pre-fire images. These are, this is the post-biopsy clip. Now, why are there no post-fire images in contrast mammography? Because there's no meaning to it, because all the contrast will be delayed and we won't see anything. Okay, this case is interesting. She had approved invasive ductal cancer here. By ultrasound, she did the biopsy. Then in the left breast, when she did contrast biopsy later, there was an abnormality here. And they said, we'll see it by ultrasound. They did the ultrasound-guided biopsy. The clip was seen in another location. It should be here, but it was here. So they biopsied something else. So then they did an MRI to double check, and in the MRI there was, it was still there, that lesion. And so they decided to do a contrast-enhanced mammography biopsy. And the contrast-enhanced mammography biopsy was done in the same way, and it was proved to be an invasive lobular cancer. And the clip was this time in the correct position, okay? So the take-home message, 2D biopsy is when do we do it? When the abnormality is not seen by ultrasound. When do we do 3D biopsy? When it is better seen by 3D biopsy and we have the device. When do we do contrast-enhanced biopsy? Also when it's seen by contrast biopsy, but we have a few tips for that. The preparation phase is crucial to the biopsy. To target your abnormality, please measure very well in the previous contrast mammo where you expect to see it, because there's no time. You have to do the biopsy within 7 minutes. Also, we recommend to wait 48 hours between the routine contrast mammo and the contrast mammo biopsy, and VAB needles are the best. During the biopsy, you should start your compression not just straight after the injection. Wait 2 minutes before you put the compression paddle. Don't use betadine or iodine because it causes false calcifications on the field of view. And it's recommended to do 2 full turns of sampling. And of course, we have to put a clip in place. And thank you very much. That was the last slide. Thank you.